So hopefully everyone can see my screen. Want to start off by saying thank you to the OR Society for inviting me to give this presentation. It's a bit strange not being able to see you all, but I am going to assume that you're all there. Today I'll be talking about modeling patient flow along cancer pathways using discrete event simulation. So as you can see from the title page, my name's Amelia. I'm a PhD student at the University College London, and I work with the Clinical Operational Research Unit. So that sits within the UCL Mathematics department. Thank you as well in advance to Luca, Christina, Yogini, and Sonia, who are my advisors who have helped me along every step of this project. So that's why they're listed here as well. All right, so here's my outline for what I'll be talking about. I'll start with a brief explanation of me and my background and my experiences and what has led me to the to this project. Then I'll talk about the cancer pathway modeling that I'm doing as part of my PhD. I'll go through the introduction to the problem, the methods, the lung cancer pathway. So spoiler alert, I'll be talking about the lung cancer pathway in detail. Next steps for that part of the project, some challenges that I've faced, especially as a PhD student and an early career researcher. And then I'll talk about some key takeaways. All right, so a bit about me. I got my undergrad degree in 2013. Well, 2017, started in 2013. I got that at the University of Richmond. And I need to mention that that's in Virginia in the US because there is a Richmond here, which is very confusing. I've confused loads of people with that. I got my bachelor's of science in math and physics. I was a math and physics teaching assistant. I was a bit of a nerd, so I was the Physics Society president, and I founded the astronomy club as well. I also did summer research in heliophysics at the Goddard Space Flight Center at NASA. So at the bottom, that's a picture of one of the labs that I was in. And on the right, that's me with my very first poster. So very physics focused, very big into math, very big into physics. After that, I totally switched directions and worked for a healthcare software company called Epic. Some of you may be familiar with it. It's based in Madison, Wisconsin. So late one Tuesday night, I didn't know what to do with my life and applied for the only job that didn't require a cover letter. And that is kind of how I found myself at Epic. So like I said, it's a healthcare software system. So while I was working for Epic, I was a technical services rep. So I was the person you would call if something went wrong in the system. And while I worked there, I partnered with hospitals one-on-one. So I worked very closely with clinicians, bed planners, and registration managers. And I was focused on the patient movement application. So patient movement, I did a lot of registration. So registering patients in the hospital. So a lot of financials in the US, of course, financials. I was the subject matter expert for the financial assistance module. And while I was working at Epic, I found myself having to learn how to communicate with clinicians and bed planners and people who worked at a hospital. And I realized that they spoke a very different language compared to what physicists talk about. So while I was at Epic, I learned how to communicate with people of a different field, people who worked in a hospital, and just try to translate those questions and issues that they had into something that I could then fix in the system. And the other cool thing about Epic was that it looked like Disney World. So this middle picture here, my office was this window right here, the top one, the window to the left. So if you ever have a chance to go to Madison, Wisconsin, it's actually worth going to Epic's campus. After that, I decided to follow my pattern and switch fields entirely again. So in 2019, I went to Imperial College of London and I got a master's in physics. So completely unrelated to what I was doing at Epic. But while I was there, I was looking at modeling light curves of low mass exoplanet host stars. So what that actually means is not super important, but I did a lot of modeling and a lot of programming in Python. Over to the right, this is just an image from my final thesis. So that's a star, that's a planet passing in front of it. Like I said, if you want to hear more about that, I'm happy to go into more detail about it. But the point is that I kind of switched gears, but still focused on modeling systems, coding in Python, things like that. And then in 2020, I moved to the University College of London, where I'm now a PhD student, like I said, working with Koru. I learned about Koru through a Google search, actually, and I realized that the research that Koru does is all about mathematical modeling in healthcare. And I thought, hey, this is a field that combines what I really liked about working at Epic, but also my love of mathematics. So while I was at Epic, I learned to talk with clinicians and people who worked in a hospital, but I also I realized that I loved being able to see what I was doing was affecting people in the hospital, affecting people here and now, and making changes in the system really made their lives better or worse. So I really loved that real world impact of what I was doing at Epic, but also loved the math because, like I said, I'm a bit of a nerd. So after sending a fangirl email to the director at the time, which was Christina, she recommended I apply for a PhD, and here we are. So I've been transitioning to operations research since moving to UCL, focusing on healthcare services. So over on the right-hand side, that's a picture of me at ORAS last year, my very first international conference. And then that's a group picture of us in Italy. All right, so that's a little bit about me. Let's go into the cancer pathway modeling. So my PhD is about cancer pathway modeling. So I'll talk about a portion of my project today, which is about using discrete event simulation to actually model cancer pathways. So like I said, I'll go into the, what is the problem, an introduction. I'll talk about the methods that I'm using. I'll talk about the lung cancer pathway and then some next steps. All right, so as with any other project, we first have to identify a problem. So what problem do we want to solve and what problem am I trying to address in my PhD? So the National Health Services here in England, they set national treatment targets for patients on cancer pathways. And those treatment targets, they're these 3 different targets I have listed out here. So ideally, within the first 2 weeks, a patient who is referred for suspected lung cancer has their first point of contact with the hospital or their first outpatient appointment. After that, within 31 days of them receiving that referral for suspected cancer, they should ideally receive their diagnosis. There is also a 28 days faster diagnosis, which is just a variation of the 31-day target. But then there's also the final target, the 62 days from referral to treatment. So ideally, a patient is treated or receives their first treatment within 62 days of their referral. And I'm just noticing that there's a couple of things in the chat, so I just want to make sure. All right. Okay, great. Glad that you all can hear me okay. That's good. I'll just keep an eye on the chat as well. But for the most part, if you have any questions, just leave those till the end, and then we can have a discussion and I'll try and answer some of your questions. All right, so we have these national treatment targets. And if you talk to cancer services from a hospital, they are typically talking about these metrics. How many patients hit these targets? And that's because the hospital's performance is based partially on how many patients hit these targets. So they'll talk about patient breaches. If a patient breaches the target, it means that they didn't hit that target. So if we're talking about patient breaches, we're talking about the number of patients who didn't hit that 62 days from referral to treatment target. So it's important for hospital performance that patients meet these targets, but I do also want to mention that it's also important for just improve patient care. So timely treatment leads to improved patient care, faster diagnosis and treatment, better quality of life. So it's also important for the patient themselves. All right, so as you know, in 2020, we had the COVID pandemic. But since then, you might have seen some of these articles come out in The Guardian or BBC. The NHS England waiting times for cancer referral and treatment are at a record high. Early cancer diagnosis plummeted in England during the COVID pandemic. The NHS is struggling to provide safe cancer care. So all of these articles are about hospitals not being able to meet these cancer treatment targets and diagnosis targets that I just talked about. And that's partially due to the pandemic, budget cuts, an assortment of things, but it's definitely highlights how hospitals are struggling to meet these targets and to reduce waiting times for patients. And if we look at cancer referrals, since I'm talking about the lung cancer pathway, cancer referrals in particular, we can see exactly what happened at the COVID pandemic. So here you see the average weekly referral. So this is a rolling 3-week average of the lung cancer referrals, just for one of the hospitals that I'm working with. And you can see it sort of is increasing, loads of variation there. And then at the first UK lockdown, coincidentally, there is a huge decrease in the average weekly referrals. And of course, that's because patients weren't going to their doctors, they weren't seeing their GPs. So they were not getting referred for suspected lung cancer. Hospital services in general were focused on other things. And then since that, we've sort of seen it climb back to where it was, again, with loads of variation. If we look at the waiting time, so this is the waiting time for the consultant-led elective care. At that first lockdown as well, we see that that waiting time for elective care sort of skyrocketed right there. And we can also look at the patient breaches, so the percentage of patients who hit those targets that I was talking about. So these are the national cancer waiting times for all of the hospitals in England. And we have the performance here on the y-axis. So in red, we have that 2-week wait, the 2-week target, the first one I talked about. And since the first lockdown, we've seen that the percentage of people hitting that target has slowly gone down. Same with the 62-day GP referral to treatment target, sort of been going downwards. So we have these national treatment targets. We have timely treatment leads to improved patient care, important for the patients. And then we have the COVID-19 pandemic with delayed diagnosis, higher waiting times, and a real pressure on hospital services to meet those targets. So we can ask ourselves, do we need to think about redesigning cancer pathways and services in order to hit these targets, provide timely care to patients, decrease waiting times, and address these issues? So my project overview and goals. The project overview for my PhD. In my PhD, I'm using discrete event simulation to model waiting times and patient flow along the cancer pathway, just from that initial referral through the first treatment. And that's because that's the time period that we're looking at when we're talking about these treatment targets. So from 0 to 62 days, that first treatment. And in modeling this are questions we can try and answer. Where are the highest waiting times in the pathway? Where are there bottlenecks? What would the best balance of resources or capacity be across different parts of the pathway? And how do temporary surges affect the flow of patients? So how did COVID affect the system? How do COVID waves, for example, affect the waiting times, resource utilization, the general flow of patients throughout the system? And my goals include designing a framework for analyzing the cancer pathway with these questions above in mind. So analyzing the cancer pathway. The tool that I'm using, like I said, is discrete event simulation. And then create tools to aid hospital decision making. I'll talk a bit more about this in detail towards the end as well, about some new things that we're doing there. But really, one of my goals is to not just do some analysis for the hospital and leave them after my PhD, but to create something that they can then use moving forward as well, and to continue to analyze their system and run what if scenarios and experiment with how certain situations affect their system. And I do want to mention that for my project, I am partnering with 2 NHS hospitals. All right, let's talk about the methods that I'm using. So the first thing to do, I guess, is to list out all of the steps that we want to follow in order to design and implement a discrete event simulation model for cancer pathways. So these are the steps that I've more or less followed for the lung cancer pathway, which is my first case study. And let's talk about this. So the first step is really discuss existing patient flow issues and project goals with cancer services. So before you start any project, right, you want to identify what is it you're actually trying to achieve and what is it that's important for them to get out of this project. The second step is to understand the pathway and key characteristics. So start trying to model the cancer pathway. What's important about it? What do we need to include in our model? And these first 2 steps really heavily involve the stakeholders. So that's indicated by this, this solid line there. Steps 3 and 4 really only involve the modeler. So that's why they're dotted, just as an explanation for what those what the dotted and solid lines mean. The third step is to actually develop the discrete event simulation tool. So take what we know about the pathway, build some discrete event simulation tool that will model the cancer pathway. Then onto the fun stuff, extract data and parameterize your model. So what is your arrival rate going to be? What is your capacity? Things like that. And then calibrate your model and validate the simulation results, make sure it all makes sense and reflects reality. Then work with cancer services in step 6 to identify feasible experiments, run the experiments and present that analysis to them, and then assess the results and address the goals from step 1. Make sure that you actually did what you set out to do. All right, so my naive first-year PhD self thought this is exactly what's going to happen, step 1 through 8, easy peasy. But really, there's a very important loop here that I did not anticipate. So after you've calibrated the model and validated your simulation results, what I found was it's not as easy as just moving on to step 6. Especially with the lung cancer pathway, I found that at this step, once you have the simulation results, they don't make sense. The first time around, they don't make sense. They don't line up with what we were expecting. So you move back to step 2 to make sure, okay, did I actually understand the pathway? Have we captured all the key characteristics? Why is it that our simulation results aren't showing what we would expect them to? And so this loop 2 through 5 and back to 2 through 5 and back to 2 through 5, I've gone through quite a few times for the lung cancer pathway. So with this, the discrete event simulation tool that we've then created is a very generic tool. So it was designed to model cancer pathways for any hospital. So as I said, I'm partnering with 2 different NHS hospitals. So I wanted my simulation to be able to be used for both hospitals without having to hard code anything. So the tool itself is coded in Python and it has an accompanying Excel spreadsheet. I'll show images of that in a second. There are a couple of key features. So they're all very specific to the cancer pathway. Here in England. So one says it's a user specified pathway, right? So the user can determine whatever network they want to actually model. If your pathway looks slightly different from the next hospital, then you can define that here. Just got a question as well. Okay, it's in the QA. I'll answer your question at the end if that's okay. So the user can specify the pathway. You can also specify patient cancellations. So patients don't always attend their appointments. You can include that feature into your model. Some resources are shared by other services. So this was a feature that I found kind of difficult to accommodate into the model itself. So at least with the hospital that I'm working with, the diagnostic resources are not just used by the lung cancer team. Chest CTs, for example, are used by COVID patients. So this is an example of a resource that is shared by another service. So to accommodate that, you can specify the % of capacity available for so that just simply scales your service rate by some percentage. For chest CTs, that's actually a very good way of getting around this issue of shared resources. For the hospital I'm working with, chest CTs, each week at the beginning, the person in charge of chest CTs and appointments for chest CTs will identify how many lung cancer patients or lung cancer referrals we have and allocate a certain percentage of the available appointments just to lung cancer patients. So this was our solution for that. There's also some very specific patient breach calculations that the NHS has. So when you're talking about whether or not a patient breached the actual pathway, so whether or not they hit or didn't hit that target, it's not as simple as when did they start and how many days after did they finish and get their first treatment. There's a couple of nuances there, like if the patient doesn't attend their first appointment, then the clock, quote unquote, restarts. So if the patient doesn't attend their first appointment, then day 0 is from the next day when they have that next appointment. So a couple of nuances there that are coded into the simulation as well to make sure that the patient breach calculations are correct. And then finally, patient care continuity options. So one of the hospitals I'm working with requires that patients stick with the same clinician and clinic throughout the entire pathway. So this is an option as well that you can include in your model. All right, so this is what the spreadsheet looks like. It's got 3 tabs. So down here on the left, it's got an introduction tab, a network structure tab, and a capacity information tab. And the introduction tab, you can define how many runs you want, the simulated duration. So if you want to run your simulation over a year, you can put in 365 days. You can include that patient care continuity option. And warm-up days, you can leave blank if you want to. The simulation will run. You don't have to specify the warm-up day. The warm-up period, it will accommodate the warm-up period and do all the calculations after that. On your network structure tab, that's where you fill out some of the arrival rate information. So here, I don't show that, but I do show the network structure tab. So the user can define, this is essentially just your transition rate matrix. The user can define the network, the structure of their pathway. So where you're going to go from referral afterwards. So after referral, you'll go to your first appointment or diagnostic test, so on and so forth. And then finally, on the last page here, sorry, network structure and then capacity information. On the last tab, that's where you fill out all your information about how much capacity you have, the probability of a cancellation, all that good stuff. The tool itself, like I said, is coded in Python. So to actually run the tool, you type one of 2 functions. If you want to just run the simulation, you'll use your do analysis function and type in the name of your input spreadsheet, so that Excel spreadsheet you have, and then you just hit go or run file in Python console if you want to be specific. You can also compare 2 spreadsheets. So if you want to run an experiment, you can compare it to your base case scenario. So you can use the do comparison analysis function. Again, just put in the name of the 2 spreadsheets you're comparing, and it spits out a folder within your Python project that has all of these plots that compare waiting times, appointments, number of appointments, the referral rates, your breach information, resource utilization, and a nice PDF that summarizes and explains all of those plots for you. All right, so let's move into the lung cancer pathway specifically. So following those steps that I had under my methods section, the first thing we did was we had an initial discussion. And in that initial discussion with cancer services from our partnering hospital, we identified colorectal, breast, and lung cancer as areas of interest. We decided to go with lung cancer first because it's a very complex pathway. It affects a large cohort of patients. And most importantly, I think cancer services said it would be of interest to start with for them. So the first thing we did was we tried to understand the lung cancer pathway. So I looked at documentation they already had and had loads of discussions with clinicians and cancer services to try and map out the pathway in a way that I could then translate into my simulation. So without going into too much detail, anything in green here is an entry point into the pathway. So you have your GP referral or your 2-week wait referrals, they call it. So you'll get referred into the pathway. You might have a chest CT or chest abdomen neck CT first. Maybe you're negative and there's no reason to move on. So you'll have a telephone appointment and you'll exit the system. Otherwise, you'll have an outpatient appointment followed by a PET scan. Your results will be discussed at a multidisciplinary team meeting. That's what this stands for. And then you might get some other diagnostics ordered. You'll have another multidisciplinary team meeting where clinicians, experts, and radiologists, nurses, doctors will all discuss your results and decide on a diagnosis and treatment. You'll have an outpatient appointment where you're informed of your diagnosis and your treatment, and then you move on to treatment. So we're only looking at radiotherapy, chemotherapy, surgery, and palliative care, since those were the biggest types of treatments that this hospital uses. So you might have an oncology appointment and move on to chemotherapy or radiotherapy, or you might move straight along to the surgical part of your pathway. All right, then the fun stuff, extracting and validating the data. So one of the good things about this project was that they use Epic. And since I used to work for Epic, I was given permission to write my own SQL queries and extract information from the system itself. So I extracted the information, wrote all the SQL queries, and I validated that the subset of patients I was looking at actually made sense. So here's a couple of examples of things that I showed them. Apologies, I know the text is a bit small, but on the left here, one of the things I showed cancer services was simply the number of appointments. So how many outpatient appointments did we have in the last year? How many PET scans did we have in the last year? How many referrals did we have in the last year? How many appointments attended or didn't attend or canceled their appointments? And in showing this to cancer services, they were able to say, yep, that makes sense. No, that number is too high. That number doesn't make any sense. And we were able to refine the SQL query over time. Yeah, they have a very good understanding of how many people have what appointments. Moving on to parameterizing the discrete event simulation model. So I've got information about the pathway itself. I know how it works. Can translate that into my input spreadsheet. I've extracted the data so I can calculate things like patient cancellation probabilities. I pulled the clinic schedules themselves from Epic, so got the capacity information. I've got information on how chest CTs, for example, are allocated to lung cancer patients. And then we can run the simulation. So here is the simulated versus the observed waiting times for 2022 for the lung cancer pathway. So these black dots are the observed values, and these lines here are the simulated values, plus or minus a standard deviation. So we can look at the waiting times, make sure that makes sense. We also looked at the observed event counts. So the simulated number of events, so simulated number of chest CTs, plus or minus 20%, with the observed in these black dots here. And so you can see some of this telephone appointment one isn't quite right. So that is an indication for me to go back and just make sure that that makes sense with cancer services. But looking at it, making sure that the number of appointments in 2022 more or less match up with reality. We can look at the simulated resource utilization as well. So how many of the servers and capacity was actually used over the course of 2022 for my simulation. We can also look at the wait time. So these are all images that are spit out by the simulation tool itself. So you can see here all sorts of variety. You can see there's not a lot of e-bus appointments. So we have loads of variety here and not a lot of data points, loads of chest CTs, radiotherapy planning appointments, so on and so forth. Palliative care, which has a wait time of 0, because palliative care is just a referral, so it happens immediately. And then we can run what if scenarios. So now we can think about experimentation that we can do with our simulation. So the first thing we looked at was what if we didn't have patient cancellations? So no did not attend, no DNAs. We have our test, our experiment here, our what if scenario in blue. So you can see the wait time decreased for, I think, almost all of the appointment types or event types, but increased for your chemotherapy appointment and your e-bus. We can visualize this in a different way. We can go back to that pathway that we have and look at, where did we have higher waiting times or lower waiting times with this what if scenario. So higher waiting times for the e-bus and oncology appointment and pre-op assessment. So maybe that is an indication that there's a bottleneck earlier in the pathway that has then moved downstream. We also looked at an increase in referrals. What if we had more patients coming to the system? What if GPs start referring more patients for suspected lung cancer? How might that affect the system? As you could expect, there are higher waiting times, more people in the system, higher waiting times. But now we see a decrease in wait times for 3 of these guys. So the CT guided biopsy, surgical outpatient appointment, and radiotherapy planning, which makes me think there's probably a bottleneck somewhere earlier in the pathway that is then affecting this. So looking back at this plot again, we can see, chest CT, an outpatient appointment is acting as a little bit of a bottleneck in this situation. The e-bus as well, in particular, the outpatient appointment following the MDT. So we can see exactly how much of an increase in wait time there was. And then doing a preliminary bottleneck analysis, I tested with a couple of different scenarios, including the ones we just saw, no DNAs or no patient cancellations, an increase in referrals. And it looks like e-bus, the outpatient appointment following by the MDT and the chemotherapy, they all had very high wait times and resource utilizations near 100%. So they seem to be the bottlenecks in the system, which is, one of the things that Cancer Services has mentioned before is that e-bus is a struggle, and the e-bus diagnostic is a struggle for them. So this kind of confirms some of their previous beliefs that the e-bus, yes, in fact, is a bottleneck. So I experimented with increasing the capacity of the e-bus by 20%, and that decreased the breach percentage by 4%. Experimented with increasing the capacity of the e-bus by 20%, but then also, what if we opened up the outpatient appointment following the MDT? What if we open that up on a Tuesday? And that decreased the breach percentage by 8%. So that's just image of that scenario 3 here on the right-hand side with the wait times here for those two. So there are clearly some more next steps, and there are clearly some further things that we need to do. So we've discussed this with cancer services before, but we do need to still identify what experimentation, what feasible experiments we can actually run. And some of the what if scenarios we've suggested are reducing staff, or what if we experimented with lower resource capacity? So what if we had budget cuts and needed to reduce staff? Or what if we had fewer chest CT appointments due to COVID-19? What would happen to the system? What might happen to the breach percentages and the wait times? What if we got some money and increased staff at certain clinics? What if we had more patient cancellations? So maybe another wave of COVID and patients aren't able to attend their appointment. What if the results are coming back as inconclusive and patients are needing to go back for a subsequent diagnostic test? What if we just think about scheduling clinics for a different day? And what if we zoomed in on a specific part of the pathway? So maybe we see that everything before the diagnosis really is a bottleneck in itself, and we want to look at that in more detail. We can zoom in on that, use the same simulation tool to zoom in on just that part and list out each step in a bit more detail, and then maybe identify a bottleneck within that zoomed in version. So there are definitely some challenges that I've faced in doing all of this. One of the biggest challenges has just been capturing all of the key pathway characteristics. So in that initial or that second discussion, that second step in the methods, where you identify what's important to include in your model, especially with the lung cancer pathway, we've had to go back and have multiple discussions, and because the simulation results indicated that, the simulation wasn't capturing all the right information. And I think a really good example of this is where I realized communication especially was just an issue. So the time between appointments versus the waiting time, these are two different concepts. And for a while, when I was saying waiting time, I was referring to the time between appointments. But in reality, cancer services was talking about the waiting time of the patient. And what the waiting time actually means is the day that the patient was decided to have, that the clinician decided to have, or to schedule the patient for some diagnostic or appointment, up until when the appointment actually happens. And here is an example of a pathway characteristic or a system characteristic that I hadn't included in the model because I didn't realize we were speaking two different languages. So for example, here on day 0, the clinician might say the patient needs a PET, a CT guided biopsy, and an outpatient appointment. Maybe the PET scan is scheduled for day 5, the CT guided biopsy for day 8, and the outpatient appointment for day 14. The time between the appointment might be 3 days between the PET and the CT guided biopsy, but in reality, that patient waited 8 days for that CT guided biopsy. And so these are two different ways to talk about waiting times, or times between appointments. But when the simulation then puts out the waiting time, we are talking about from when it was ordered to when it actually happened. So this was an example of how capturing the system characteristics was difficult, communication was difficult, but an example of where I needed to go back and re-edit or edit the simulation tool again. Extracting the correct subset of data. So definitely a blessing and a curse to know the Epic software so well and to know the data structure so well. Like I said, I was given permission to write my own SQL queries, and I initially started searching over all of the pathway records to find any suspected lung cancer pathway records, thinking that this would identify the correct cohort of patients. But through showing these summary statistics, summary graphs of the actual data I'm extracting to cancer services, we've identified that, maybe this number isn't quite right. This number isn't quite right. That's not right. And so the SQL queries have evolved over time. Apologies, this is very blurry. It's partially on purpose, so you don't see all the nitty-gritty details, but this is just how one portion of the SQL query has evolved over time. Yeah. And I've sort of already talked about this, or maybe alluded to it, but involving the relevant group of stakeholders is definitely been a challenge. I found that over time, we've been involving additional clinicians or just managers or other people who should have been part of the project from the beginning, but maybe we didn't have a good understanding of the scope of the project or exactly which direction the project was headed in. And so people have sort of joined over time or come in with their opinions and advice and expertise. And so the lung cancer pathway in particular has evolved over time. So don't look at the details too much, but the point is that the pathway map itself has really evolved through many multiple discussions. And again, I also alluded to this a little bit, but just communicating the goals and limitations of the project has been a huge challenge. So especially with the wait time versus time between appointments, that was a communication issue. And communicating exactly what this project is about, what it can and cannot do, and what our goals are for this project. I've gotten better at over time, but has definitely been a challenge for me. And I think this is an area where PhD students in OR who are trying to work with people in the real world, trying to implement a project in the real world, where PhD students can definitely use some help on just this communication aspect. I think this is a unique feature to my PhD versus the other PhD students in the mathematics department, where I have almost this whole consulting portion of my PhD, which is a whole other sort of subset of skills that I've had to work on and have learned and definitely gained some skills from working at Epic, right? But they've also gotten better and evolved over time. So there is another case study. So I mentioned I was working with two hospitals. So the second hospital I'm working with, we are modeling the breast cancer pathway. And taking all these challenges into account and thinking about how I can do better this time around, we've gone into this other hospital and had our initial discussion. We talked about exactly what pathways we might want to model. And the breast cancer pathway was definitely the pathway to model for this hospital. So breast cancer is a challenge for this hospital. There's a low percentage of patients who are actually hitting the 62-day treatment target. They have very high wait times. They all around kind of struggle with this pathway and making sure that patients are getting that timely care. So this was definitely a pathway that we could model and try and see if we can't tease out some information that might be useful to them. One thing to note as well is that this hospital uses a different electronic health record system, so they don't use Epic. So that also means that they have a totally different data set. So I can't go in and write my own SQL queries this time. But so after our initial discussion, again, following the methods that I showed, we went about understanding the cancer pathway, the relevant characteristics, mapping out the pathway as well. So again, without going into too much detail, anything in green here, you'll enter into the pathway. Anything in red is you leaving the pathway. So you'll enter in with a GP referral, typically go to the breast one-stop clinic, go to an MDT, might have some follow-up appointments, followed by some diagnostics, a second MDT, followed by your different treatment branches. Right. And I want to mention that the breast pathway map has not evolved yet. Granted, it is early in the project, but I also think that one of the reasons that the breast pathway hasn't changed as much as the lung cancer pathway has changed is because, learning again from my experience and from the lung cancer pathway, right from the start, we had all of the clinicians, all of the radiologists, all of the cancer managers in one call, in one Teams call. We mapped out this pathway. After an hour, we were done. We had all the information that we needed. The pathway was set. We had all the experts. Everyone could sign off on it and say, yes, this makes sense. This is right. And so we haven't had people sort of come and filter in and out of the discussions. So just to finish off, because I know I'm running out of time, bonus case study. So there is one other area where I'm working with a hospital to implement the simulation tool. So I am currently working with the first hospital to apply the tool to all of the cancer pathways. And I think this is very interesting and an interesting portion of the PhD, because this is less about developing a tool for end users to use. It's more about developing a tool, but also streamlining the process so that I eventually don't have to be involved. So it's a more hands-off approach. And as part of this portion of the project, we're talking about designing a methodology that includes the pathway mapping, writing SQL queries that maybe can be reused for each pathway. So writing these data extracts so that when we want to roll out this simulation tool to another pathway, we can just follow, all right, in discussion number 1, we need all of this information from all of these people. Here's who needs to be involved. In discussion 2, we extract all of the information from all of the pathways, and here's exactly what we need to do that. And then validate the information. Who needs to be part of that validation process? Can we maybe use the NHS cancer waiting time reports that already exist? So on and so forth. All right, so some key takeaways. I want to say that the first thing is the cancer pathways are very complex, and I think they require very careful modeling simplifications, especially if you're looking at the cancer pathway from initial referral through first treatment. That is, you're capturing quite a bit of information. So one of the things that makes this difficult is that, again, at least with the hospital I've been working with, they share resources. So resources are shared among other services like the chest CT that I mentioned. You have a high variety of paths. So the pathway maps I showed are a very simplified version of what happens in reality. In reality, patients can take very many different versions and varieties of paths, versions of that pathway map. But what we mapped out was the ideal simple version of that. But knowing that that is a modeling simplification, you have to take. And then patient behavior. So we've included patient cancellations into the model, but there's other things to consider as well. Cancer is a very scary thing, and patients don't always engage with cancer services. Sometimes they get scared and they need time to decide on what treatment they want to take. And that's something that is very hard to model in your pathway, or at least something that you need to consider. Do I need to include this characteristic in my model? But with all of this, I think operational research projects, they have the potential to impact services in the real world. I really think that they have the potential to do some very good stuff. Even just showing basic information or basic results has shown to be very useful for cancer services and the ones that I work with. But I also think it's important to mention that, this requires pretty close involvement with those that the project will affect. So if you want to make something that will impact and be used in the real world, it will take extra time, because you have to make sure that the people who are going to use it are involved in the project itself and are involved in the early stages. So one of the key takeaways, involve as many people as possible early in the project. If anything, just to avoid having a cancer pathway evolution or a SQL query evolution like I have. I think one of the things that's definitely underrated in our field is just learning to communicate across fields, across disciplines, across hospitals. That is a skill in itself. I think it's something that takes time to practice. So with the breast cancer pathway, for example, when I presented the discrete event simulation, instead of blank stares, I was met with people who said, great, that makes a lot of sense. Awesome. Because I had learned just to present the simulation tool in a way that they might understand, so that they can ask, informed questions. And then finally, ask, I quote unquote, stupid questions. I think maybe silly is a better word for it. But I think it's important to ask questions that you might think are obvious, like the waiting times. I thought that was very obvious what waiting time means. In reality, it was the completely wrong terminology, and we were sort of speaking past each other for months. So ask questions that you might think are stupid, but they're not stupid. They'll save you loads of time. All right, okay. That is everything that I had for you. So thank you so much for listening. And I can see that there are a couple of questions in the Q&A. So I'll start with I'll check the chat real quick as well. Okay, so there are a couple of questions in the chat. I'll get to those in a second. Okay, so the questions in the Q&A portion. So the first question is, which step of the discrete event simulation model framework would you say is the most challenging to implement? Oh, that's a very good question. Okay, I'm gonna go back to the actual step in the methods to remind myself. All right, there we go. Which step of the model framework would you say is the most challenging to implement? So I think it depends. So for the breast cancer pathway, the most challenging so far, I think, well, we're still in the data extraction process, but I think understanding the pathway, I think this is a very difficult task, because you're sitting with loads of cancer services to try and understand exactly what is important about the pathway. For the lung cancer pathway, I do have to say that the data extraction has got to be up at the top of my list for most complicated and most difficult as well, because I think I maybe know too much about the data structure. For the breast cancer pathway, I'm not the one doing the data extraction, so it's a bit easier. But as far as implementation goes, I think step number 2 is really where you're trying to translate what their current issues are, what the current pathway looks like, into something that you can model. And that in itself is going to take quite a bit of time. Another person asked, what do you think are the 2 key aspects that cause increased waiting times currently? And do you think COVID-19 is still contributing to this now? Yeah, very good question. So I think 2 key aspects. I think one of the reasons we see high waiting times is, so it depends on the service, but I think there is still a COVID backlog for some services. So some patients are still waiting for their appointments. So that is definitely contributing to the high wait times. I think another issue is maybe lack of resources. So budget cuts, general lack of resources. I do think that COVID-19 is still impacting services, not so much for lung cancer anymore. For a while, there was talk about the patients who didn't come in for suspected lung cancer, will they be returning to the system? According to one of the clinicians from the cancer services team, the answer is, at least for the lung cancer pathway, no, because they died, which is a very grim thing to say, but that maybe isn't contributing so much to the lung cancer pathway. But I think for other services, that backlog is definitely still there. Someone asked, I wonder if your model includes treatment times, for example, 45 minutes for radiotherapy. Yes, so the way that we've done treatment times and service times in general, I'm not sure that this is the best way. So if you have any advice, definitely open to it. But for our capacity, we're looking at the system on a day-to-day scale. So we're looking at quite a zoomed out version. So we're not considering 45 minutes versus 51 minutes. So our service rate distributions are just normal distributions, partially because we don't have that information to extract, and partially because we're looking at sort of one step away, we're looking on a day-to-day scale. So the treatment times are just calculated by how many appointments you have available in that day. So if you have 5 appointments available, there is some stochasticity. So you might have 4 or 6 appointments available, but it runs on more of a day-to-day scale. And apologies, I wish I could see your faces so that I could see whether or not I've answered your question. So, all right, I think I have time for a couple more questions. So I'll go down the list. The next question is about, what about the clinicians or doctors and them working in other areas of the hospital? Is that a limitation of the model as it seems contained? So apologies, I might not have understood your question entirely. I think what I'm referring to there, if you're asking about the shared resources is more about, so the lung cancer clinicians only work on the lung cancer pathway. So we do have clinicians that are just for the lung cancer pathway, and they only have outpatient appointments for the lung cancer pathway. But the shared resources, like the chest CTs, for example, those are shared by other services. So a COVID-19 patient might have a need for a chest CT there. So it's less about where they are specifically in the hospital and more about just other people coming in and needing to take part of that resource. All right. And Caitlin, we have 1 more minute. So should I answer 1 more question or?
Yeah, happy for you to answer all the questions. Depends on your time really, and then if anyone's got to leave, then that's fine too, but up to you.
Okay. All right, I'll answer the question in the webinar chat. Oh gosh, there's so many questions. Okay, I'll answer the next question. Christina's, did I read your first plot on waiting times right, that 0% patients meeting 62-day target is near 0? So that might have, I'm not sure which plot you're referring to. It might be the first one. I'm not sure which plot you're talking about. We can talk about that later though, Christina. All right, apologies, I didn't really answer that question. Yeah, Christina, I'd love to talk about that later. If you have more questions as well, I'm happy for you to reach out to me, or otherwise I will see you at ORAS or OR65. But thank you so much everyone for attending. Again, I'm just a PhD student, so if you have any advice, I would love to listen and see if you have any sort of suggestions. But this is definitely ongoing, and hopefully I said some things that you thought were interesting. So yeah.
Brilliant, thank you. And I'll send across the questions as well, and we can always send some written responses across for them. So thanks everyone for joining. And thank you, Amalia.
No problem. All right, thanks everyone.